said, welcome to the webinar, Leading During a Public Health Crisis, Core Competencies and Strategies to Support the Workforce. Again, if you're just joining, feel free to type your name, your organization, and location in the chat so we can see who's in the room. And I want to go ahead and hand it over to Diane Fabi King, who is with HRSA, to give us a quick welcome.
Thank you so much. Welcome, everyone. Thank you for joining us today. I'm very happy to be with you. My name is Diane Fabi King, and I'm a Senior Advisor in the Division of National Health Service Corps in the Bureau of Health Workforce and Health Resources and Services Administration. This is the 10th webinar in our 2024 National Health Service Corps Empowerment Initiative, Advancing Clinician Wellness and Health Equity. This HRSA initiative was designed to help NHSC participants and our new clinicians in the field to prepare for the rewarding and what we think may be challenging experience of serving in health professional shortage areas across the country. We couldn't do it without you. Today's session leverages insights and best practices from the COVID-19 pandemic to enhance our readiness for future public health crisis that may be coming sooner than later. The extent to which we have prepared can help eliminate some of the uncertainty and what I would think is instability that comes with a public health crisis. It can mitigate its impact on our patients and health care workers, which maybe some of you have experienced already. We are grateful for the work you do, and that you've made this time to attend our training really makes me feel that it is valuable and that you value the work that you do as we do too. I hope you enjoyed today's session. You're going to have a great day with these ladies. Thank you.
Thank you, Diane. My name is Sabrina Edgington. I'm the Senior Director of Justice, Equity, Diversity, and Inclusion Initiatives at the Association of Clinicians for the Underserved, and I'll be serving as your moderator today. Again, if you're just joining, feel free to type your name and organization in the chat so we can see who's here. As Diane mentioned, this is the 10th webinar we've conducted as part of the National Health Service Corps Empowerment Initiative. If you missed previous sessions, you can find the recordings and slides on our webinar information page, and I'll ask one of my colleagues to go ahead and drop that link in the chat. Today, we're exploring how a public health crisis impacts the well-being of our workforce and how you can support clinician well-being and each other during a very difficult time. And this webinar is broken up into two parts. The first will explore core competencies that leaders can work towards to prepare their workforce. And the second will focus on the emotional and psychological phases that we see in the healthcare workforce during a crisis and strategies to support their well-being. Next slide. I'm really excited to introduce our speakers, Angie Im and Dr. Ijeoma Nwachukwu. Angie Im will be leading the first part of the session focused on leadership core competencies. Angie is the Associate Director of Research and Policy at Healthcare Ready. In this role, she oversees Healthcare Ready's portfolio of research projects with government agencies and private partners. Healthcare Ready has done a lot of work supporting health centers during public health emergencies and has a lot of great resources. So if you haven't already become acquainted with them, please be sure to check out their website and the resources that they offer. You can find them at healthcareready.org. Dr. Ijeoma Nwachukwu will be leading the second part of the session on strategies to support the healthcare workforce during a crisis. Dr. Nwachukwu is a mental health consultant with Project Hope, a global health and humanitarian organization that partners with local healthcare workers and healthcare systems to provide urgent relief during crises. In her role, she delivers mental health training and resilience training sessions to healthcare workers across the United States. Now, before they get started, I want to go over a few housekeeping items. I'd like to just let you know that this webinar is being recorded, and a link to the recording will be emailed to you in a few days. The PowerPoint slide for today can be found on the webinar registration page, which we'll link in the chat along with direct links to the slides. If you missed any of our previous webinars, you can find the webinar slides and recordings and transcripts on that webinar information page. We'll have time for Q&A at the end of each of the presentations, and we'll ask you some questions throughout the presentation that will hopefully spur a conversation. Please type any questions you have in the Q&A box, which can be found at the bottom of your screen. Also, feel free to use the chat box if you want to talk to each other, to share comments and observations. If you have a technical assistance question, please contact my colleague Molly. Her contact info is pasted in the chat. Polling will be used throughout the presentation using the Slido platform. Slido has been a really engaging way that people have been able to share their own experiences, and that's part of the NHSC Empowerment Initiative, is to help people learn from each other and build a community and network of learning. And you have two options for responding using Slido. The first option is to use your camera and scan the QR code on the polling slide and on your cell phone, and you can enter the password provided, which will take you to the Slido website for this webinar. You can also manually navigate to the Slido website by using the link provided on the slide. So each Slido slide will have a link, and entering a numeric code and then entering a passcode, which will also be on that slide. Once you open Slido manually, it'll automatically update with the next polling question as long as you keep that Slido window open. So go ahead and keep it open if you're using your computer to respond to the polling questions. Finally, we really appreciate your feedback on today's session. So before you leave today's session, which runs 2 hours, please complete the survey at the end of the webinar to let us know how we did and how we can improve our trainings. To see closed captions, click on the CC icon on the bottom left corner of the webinar window. So let's go ahead and practice using Slido with a poll on your NHSC roles. Go ahead and use your camera, scan that QR code, and so that you can respond to the poll, or just go to slido.com and enter the numeric code and passcode, and let us know, what is your role related to the National Health Service Corps? And we'll give it just a second for people to respond. Not seeing any responses yet, but please let us know in the Q&A if you're having any trouble accessing the Slido poll. All right, so we're getting a couple of responses here and another who is responding at the moment. So we see that we have some site staff here, those who are in management, as well as clinician. Thank you so much for responding to the poll. All right, well, let's move forward. I'd like to share the objectives now for this session. We do have a lot that we're covering today. What we hope that you walk away with is an understanding of leadership competencies for responding during a public health crisis. We hope that you gain understanding of actions that can be taken to plan and respond to a crisis. We also hope that you learn various stages of the public health crisis and their impact on mental health and strategies for preventing burnout among staff. So thank you so much to our speakers and to those who are attending. I'm going to go ahead and hand the mic over to Angie now to begin our presentation.
Awesome. Thank you so much for that introduction, Sabrina and Diane. Really, really appreciate being here. And most of all, I just want to send a big thank you to all of you who are on the line today, or maybe watching the recording, to pick up on this session. It's, I think, the biggest gift to ourselves to be able to step away from our work. And I know it's a thing, so I really appreciate being with you here today. As Sabrina mentioned, my name is Angie Im. I'm the Associate Director of Healthcare Ready. Prior to Healthcare Ready, I worked for several years at IBM in management consulting and startup works of digital health and AI. And for the better part of the past 4 years, I've been working at Healthcare Ready, which is a nonprofit 501c3 that works to ensure that the conversations that are necessary between public sector and private sector are happening to make sure that patients can continue to have access to their medications and health services during disasters. In that role, I support our Emergency Operations Center with staff who are working on developing threat assessments and situation reporting during disasters. they're often fielding requests for information or support from health systems and government agencies and patients. So thank you. And I am delighted to be here today to talk about a topic near and dear to my heart: disaster response and the role that each of us can play in supporting and leading our teams and organizations through crisis events. Before we dive into kind of the core competencies for leadership in public health crisis, I want to take a moment to talk about and reflect on what is a public health crisis. A public health crisis is when an event happens that impacts the community health and well-being of those around us. This could include anything from an infectious disease outbreak, like we saw in COVID-19, or just a natural disaster event, extreme weather, hurricanes, and so forth. Anything that's happening that would prevent our community and our patients from accessing medications or their typical healthcare services too. So today we'll talk a bit about the strategies for being an effective leader through crisis. That involves inspiring and communicating with our workforce, how we foster a culture of support and well-being, because as we'll touch on later, culture eats strategy any day of the week. We'll also want to talk a bit about methods and best practices for communications during crisis events, and also how we as leaders can demonstrate a willingness to improve and adapt systems when there's change all around us through crisis. For those of you who are joining, thank you for being on. The Q&A is available for any comments or questions that you have. This session is going to be as useful to you as much as we're engaging in it, because here's the thing. We've all been through these events. We all have experiences that we can share and learn from one another. So as much as you can, drop in a question or your comments or something that you've seen in the chat, we welcome that. A recent literature review looking at studies touching on leadership competencies needed for public health crisis found that there are these kind of four intersectional areas that are important for leaders to have. They involve task competencies, really around operational tasks for preparing and planning, improving our communication and collaboration. They involve people competencies, not my favorite phrase, but just in terms of how we work with each other, how we communicate, how we care for one another, and making sure that what are we doing to lead with empathy and awareness. The third being adaptive competencies around what we can do for decision-making during crisis events, how we approach decisions when there might be limited information. And also touching on influencing the contextual factors that may impact how we show up to lead our teams and our organizations during a crisis. That can involve anything from structural, cultural, and political, any other kind of environmental factors that can impact either how we're leading or just impacting the success of how we lead. So the next few slides are going to talk about strategies for demonstrating or to enact those competencies that are important for leadership in public health crises. The first, when we talk about task competencies, we're really focusing on the knowledge, skills, and behaviors that are required to manage and respond to a disaster event. So during a crisis, we're called on to perform a number of different tasks and a range of different activities. They can include anything from identifying the crisis to developing the emergency preparedness protocols, managing and implementing the protocols, allocating resources. For those of you who have been a part of the clinical team or been a part of the response team responding to this event, you know this very well. There are some foundational components that will support you throughout every stage of this response. And when we think about disasters, we think about it in phases, 4 phases: mitigation, preparedness, response, and recovery. Communication and collaboration is an important aspect in every step of those phases. Um, Thinking about the messages that we'll convey to our teams internally, as well as to our external stakeholders, is a founding block to how we approach our competencies throughout the nature of a response. Our ability to build collaboration and to make sure that we're pulling in the necessary colleagues and teams in order to operationally respond to an event relies on how we communicate, including the frequency of communication, the groups that we're communicating with, the content of our communications, and how we're engaging these groups to also share the information that they have from their perspectives. So these 3 competencies are often interrelated, as we see in previous studies. For example, communication and collaboration are so important in being able to conduct effective planning. If you're a shift leader and you have visibility to what your team is doing and the operational plan for when your team will be working and what they'll be focused on, that communication involves not just your team, but all the teams that come before and after and around you, right? And so that's why communication and collaboration is such a critical component to this. One other aspect that I'll touch on for communication and collaboration as a task competency is also media communication. So as leaders, we might be expected to speak with external stakeholders, in particular media, to extend our messages about what's happening in our facilities and what our plan is. So I think as leaders, one of the things that you might want to be asking yourself is, do you know what your organization's expectations are for you to communicate with the media during a public health crisis? Is it you that would be speaking with the media, or is it another representative of your organization? Are there folks and tools that can help you build out these talking points and just make sure that you're building alignment across your organization in your messaging before you share it publicly? This is a list of several kind of operational tasks that are related to crisis management. I'll touch on a few of them here. I would love if you think about examples of these things, examples when you've seen it done well, maybe not done so well, and drop it in the chat. If you have questions, feel free to raise your hand as well, and Sabrina will unmute you to be able to speak. So, early recognition. As a leader, one of the things that will help us in to be able to assess a situation, assess the urgency of the situation, is our experience levels. The more you've been involved in emergency planning and preparedness through exercises, through planning, maybe through a working group within your organization, the more we're able to approach a situation with the understanding of how we're going to respond. That feeds into communication and so forth. And so what your team will be looking for from you is a bit of early recognition, demonstration of early recognition, that you're seeing what's happening, what's forming. I'll give you an example. So in the early days of COVID, this is the December, January timeframe. Healthcare Ready was involved in a few conversations with different government partners and private sector partners. No decisions had been made yet, but we had our eye on the situation. Before any major announcement was made, before a shutdown was called, our leaders had decided to put our teleworking plan into place. They knew the signs of the upcoming situation, and they communicated with the rest of the team what they expected would happen, why they were making the decision to move us to telework, even though no one else had. So it gave the rest of the staff a lot of confidence and inspiration, knowing that our leaders knew what they were doing, that we could depend on them for making informed decisions, even when maybe information was limited. Making critical decisions as a leader, we're making critical decisions all the time. In the context of crisis management, though, what we really mean here is strategic decision making. So for those of you who are joining, who are clinicians, who are administrators, any role, there's a ton of operational tasks that you have to do when a crisis is triggered, right? As a leader, you want to be thinking about what are the strategic decisions that I need to make that are most urgent. Your role as a leader is really to empower the rest of your teams, if you can, so that they can deal with the operational tasks. Sometimes that's not an option. Let's face it. Most of you here are probably wearing 6 or 7 or 11 different hats. We may need to be focused on all the things regardless. But by strategic decision making, I'm really referring more to what are the organizational decisions that we need to make about operationality of our facility? Are we going to continue to expect our staff to show up on normal schedules or maybe even overtime schedules to be able to respond to this public health crisis? What are our overall messagings? What's the timing of our overall messaging, not just for today, but for the next week and for the next month, both to our patients, to our board, and the public, for how we want to communicate? That's what we think about when we're talking about strategic decision making. Good decisions will have the hallmark of being reaffirmed and confirming core institutional values. I'll breeze through just maybe 2 more of these real quick. But in terms of talking about orchestrating vertical and horizontal coordination, I think you know all of what this is about. If we're responding to an event, how are we reporting up, managing up to our leaders, as well as reporting all around us through our staff? How are you working together within your vertical teams, but as well as your other teams across the board? So as a leader, especially if you're managing a health center, some of your colleagues horizontal to you may involve teams outside of the clinical teams, your IT team, your finance team. You're probably really familiar with this already through, for instance, the recent Change Healthcare attacks, if your facility was affected. How will you be communicating across the board in order to develop a coordinated response as an organization, as is necessary for what your patients will want to see in response to an event? Lastly, I'll touch a bit here on learning. So learning during and after an event is so important. There's going to be a lot happening during a crisis event. And although it's hard and kind of complex sometimes, you want to be able to capture as much as you can from those events through an after action report or a debrief with your teams. That could look anything from a morning and end of day debrief for things that have happened, so you can capture new processes that are happening in response to the crisis event. It could involve an after action report where you take a look at how the team reacted, what new problems came up, and codify solutions that came up during that event. maybe even months afterwards. The thing about the learning is that there's high symbolic value in it, in demonstrating with your teams and with other external stakeholders, saying, I took a moment to take a moment to pause and reflect on things that went well, things that could have gone better. It demonstrates accountability on our part, that we care about improving our response for the next time. So that's where the high symbolic value comes from. People competencies. So I mentioned there's 4 areas of strategies that we'll cover. This is the second one. Think about an event that you went through with your teams or in your organizations at whatever level. This might have been an experience years ago, or maybe in COVID or more recent. Think about the one person that you look to give you a bit of relief because they were so confident or so calm, or whatever it is, the words of wisdom that they shared with you during that event that made you feel like you can get through it. People competencies focus on the skills and behaviors required to make sure that we're managing the relationships that are necessary to lead a response to a disaster. What our teams want to see are leaders that are able to engage, ourselves as members of the staff, but also those around them. I remember during COVID, there was a regular staff meeting that we would participate in. It happened once a week. And I can't say that we learned anything new in the staff meeting every week, but I will say that our leader who facilitated that call each week, she was the most calm person. And no matter all the things that were happening, the cadence of her tone would not change. It was reassuring. And she touched on the important things that we cared about. Didn't gloss over our questions. She addressed them and really led with empathy. Examples of empathy during a crisis event could be as simple as being a good listener, listening without judgment, expressing curiosity. So if a staff member is vulnerable and they share some information with you, maybe that you don't agree with, can you still ask questions to learn more about where they're coming from or where their concerns are? And also identifying ways that you can help or connect them with resources during a crisis event. Seeing examples of empathetic leadership will not only help to build relationships and really build trust across the organization during a stressful period, it can overall reduce occupational stress, which is so important during periods of crisis, which can lead to burnout. One example and story that we've heard in doing some of the mental health training and resiliency trainings that we've done at Healthcare Ready is there was a clinic at the height of COVID. The clinic administrator was going through a lot of experiences, not only just losing staff and also addressing patient losses as well, but also just having to deal with the unknown. That level of stress built to a point for that clinic administrator where she came to her colleagues and said, I am at a point right now. And she shared she was vulnerable with her colleagues and explaining how she was feeling the level of stress. Sometimes as leaders, we can feel compelled to show only confidence and to be perfect in our response. But that's not what leadership is, or that's not what all our staff is looking for. What they're looking for is an empathetic leader, someone that will listen and respond to their needs to the best of their ability. Sometimes that means showing a bit of vulnerability. Adaptive competencies. How many times have we gone into an event or a situation and say, yeah, got a plan for it. The CMS emergency preparedness rule, got a bunch of policies for this. Um, and then you try to follow the policy that you set out when you're doing your emergency preparedness planning. You find out, oh, can't get the supplies that we had meant to have for this, responding to this type of event. Or, oh, we have an approach for this planned out, but we can't follow it because the staff that are supposed to be implementing our policy aren't here. Adaptive competencies focus on the skills and behaviors required to respond to the dynamic nature of events. So a leader's ability to conduct decision making with sometimes limited information, and also how to think about systems level thinking, how we're going to collect data from other sources in order to make better decisions. So one of the core competencies for being an effective and adaptive leader is to make sure that we're engaging others across the team to be able to respond to an event. Part of this requires the whole team knowing what their role is in the disaster, in the response to the emergency. So what I mean by this, for instance, is as the leader, you're not going to respond to every question or situation. But if you can start with helping your team know what their role is in the response and empowering them, giving them the tools and the resources to do their jobs, that will allow you to be a more adaptive leader, to be able to extend your ability to collect information, respond in different ways to an event. Tacit knowledge of the problem and systems thinking and sense-making abilities have a broad, meaningful impact on how decisions are conveyed to staff, especially when decisions rely on incomplete information or evidence. So think about how you will rapidly build your knowledge base during a response to an event that you might not have all the information for. Some of this involves partnerships, developments, and knowing information that's outside of your organization. I'll go into this a little bit later on into the slides, but that involves things like how you're getting information from your local emergency management or local public health departments, maybe your state departments, to respond to an event. Running through the rest of the slides a little bit more quickly. So lastly, we get to contextual factors. So contextual factors shape how our competencies are demonstrated. They can include anything from hierarchy, lack of team cohesiveness, resource allocation issues, whether our teams are structured to be distributed or central. Think about the structural factors that will impact your ability or your intent or how you'll respond to an event. What are methods for overcoming that or mitigating those circumstances? Earlier, regardless of the type of nature of the planning that we have and the level of comprehensive of planning that we have, one of the things that will help most in the response are the cultural factors that are associated with your team. What kind of culture have you set up as a leader to make sure that the team prioritizes communication, transparency, and collaboration? A lot of this is based on trust, and these aren't things that we necessarily build just during disasters, but it involves a lot of how we invest and build relationships with our colleagues prior to the disaster. Preparing for staffing needs. Strategies to increase staffing. So we saw this a lot of health centers are grappling with this now, but making sure that we're empowering staff and retaining them to the best of our ability. Um, During a crisis event, when we deal with a medical surge, we can result in a situation where we don't have the necessary teams or staff that are able to either get to our facilities, or maybe they're out taking care of their families because they've been affected by this event themselves. So you want to think about different strategies to rapidly increase staffing during a crisis event. If you have seen a great example, if you have an example of how you've rapidly increased staffing in your organization in the past, would love for you to drop a comment in the chat. Some of these examples, and this is not an exhaustive list, is where you can pull retirees to support with in-person or virtual care. There are a number of agencies that are out there that you can coordinate with that leverage locum tenens. How can you leverage existing local training programs to identify students to hire as support staff during clinical rotations? And what kind of processes will you have in place to onboard staff, new people quickly, to get them familiar with the layout of your facility, what their roles will be, where they'll access sources, so forth. If you have shadow opportunities at your facility available during steady state periods, so prior to a crisis event, think about how that can lead into popping up additional resources during a crisis. A few other items to think about for making sure that we have the staff necessary during an event. Plan for flexible work options. There are so many reasons why this is important if we're able to implement flexible work options in our facilities. And I know that that's not possible all the time. But think about some of the options for doing this is develop some part-time posts. So if there are difficult to fill positions, there's research has found that doctors feel more energized and more ready to do their work if they know that their time and being able to do certain hard to fill positions are limited, or if they know that they have a counterpart to be able to do the work. So what I'm referring to is job sharing. How can you define an alternate work schedule where there might be two staff doing the same job, so that as you increase the response to a medical surge, not a single person is bearing the burden too much. Think about ways to allow for voluntary reduced hours and how you'll manage and respond to that. People will just need time, and recognizing that and how you might encourage them to take the time they need to if folks aren't comfortable saying it out loud, is another way that you can show up for your staff and your team. Providing telework options also requires a bit of resourcing upfront. So as you're able to, as a leader, think about whether or not it would be helpful to have a working group, have a discussion with your team about what it would look like to provide telework options before a crisis event happens. Next, so we have a poll next. Would love for everyone to kind of weigh in a little, reflecting back on what you saw during COVID. Your experiences are so valuable here. Think about what strategies worked for your organization to address staffing needs during the COVID-19 pandemic. You might want to share how your staff was affected throughout the COVID-19 pandemic. Maybe in some cases, we'll talk about that next. I'm going to ask one more question after this one. What barriers did you encounter when you were trying to address staffing needs? That might involve administrative barriers, maybe resource barriers. Maybe you were the person that wanted to suggest a different way for working your schedule and something happened. Would love to know more about that too. So that's the next question coming up for this one. So Sabrina or oh, start. Awesome. All right, we see a couple of responses here for what strategies worked for your organization to address staffing needs during the COVID-19 pandemic. One was reducing in-person clinics to phone visits. You hired contractors. If you answered any of these, feel free to raise your hand. Would love to hear from you about how that worked or any kind of intricacies associated with that process. Reading off the others, someone else said reducing work hours so that everyone still had a job and no one was laid off. That's it. An incredible show of team investment and just recognizing and showing with everyone like we are all willing to make sacrifices. Thank you for sharing that. I love this response also. Volunteers for new screening practices and COVID-related needs. Absolutely. Where can you get volunteers to staff? There's a lot of administrative ramping that also has to happen during a crisis response event. Where can you fill in non-clinical volunteers too for said needs? Moving on to the barriers question. Again, what barriers did you encounter when trying to adjust staffing needs? Would love to hear if you have an example for the barrier that you encountered and how you overcame that barrier. Feel free to respond to the Slido and we'll show those responses momentarily. Just a few slides to wrap up here afterwards too. All right. If anyone would like to come off mute and share too, absolutely love to hear from you about what region you're in and how you overcame those barriers. Feel free to raise your hand if you'd like to come off mute.
Angie, I'll read a couple of the comments that are in our webinar chat. So one, Foster mentioned that working at a CHC during COVID in a city with huge out-of-work hospitality workforce, they really benefited from volunteers for things like COVID screening, vaccine, event setup. And then Foster also mentioned that they realized that a lot of workflows really depended on their nurses and MAs that could be done by non-medical staff effectively.
Those are great examples. Thank you, Foster, for sharing that. That's critical. So really understanding what the new workflows are and being able to reassign them to other volunteers. That's an excellent example. We also see in the Slido response, security clearance lightened for emergency hires. So having a rapid way of integrating new individuals onto your staff is an excellent way to overcome the barriers. And someone else mentioned what we had to deal with was also emotions behind changing into part-time employment. Overall, staff were empathetic and understanding of this decision. Thank you for sharing that. I can only imagine the type of trust that you needed to have with your leaders in order to share in the empathy and understanding. It's an excellent point. Right, so I know we have a couple more responses coming in the Slido. I invite Sabrina to share them too, or Foster if you're able to read from them. And I'll just go quickly through just the last couple of slides here. This slide says strategies for assessing hazard risk. What this is about is really for as leaders, how we're going to be sending clear messages to our staff or clinicians that they are valued. So what we mean by this is, what are we doing as organizational leaders to assess what are the highest areas of risk to our staff and being able to respond during a crisis event? And what kind of mitigation factors, what kind of protective tools will we be able to provide in order to reduce the risk that our clinicians and our staff are being exposed to and continuing to do their jobs? An example of assessing risk on here is anything from, so during COVID-19, an example of how we assess risk was, how is COVID-19 being spread? What were the aerosol generating procedures that were happening? What can we do to implement more controls to protect our staff and patients? It is so critical to their morale, mental health, and well-being that we as leaders are both anticipating the challenges and concerns, and showing and speaking to and demonstrating that we're going to be proactive about these things. Some of the ways that you want to be thinking about controls are engineering controls, administrative controls, and safe work practices. So a few quick examples around here. Engineering controls refer to physical barriers that are developed to protect our staff and patients. In COVID-19, that might have involved partitions that were available, separating rooms, separating patients, and making sure that patients were guided appropriately to where they needed to be treated without having unnecessary interaction. Administrative controls refer to the policies and procedures that we have in place for how we protect both patients and our staff and our clinicians from being overly exposed to considerations. One of those common policies and procedures that we had in place included restricting the number of personnel entering a particular room, or restricting areas that people could travel to, obviously restricting how many patients and non-patients could be in the same place. Safe work practices. Safe work practices, I think we're all familiar about what these involve and how we're implementing policies and procedures for clinical response. How are we going to communicate this consistently and uniformly to our staff and our clinicians and our volunteers to make sure that they're following the policies and procedures appropriately? So implementing hazard controls. Here are just a few examples for what leaders can be thinking about in order to reduce risk exposed to their staff and clinicians during a crisis. Communication is key. So when our organizations are hit by a crisis, staff are looking to you to understand what is happening and what the plan is. Part of that involves us interpreting the situation. And they'll rely on our interpretation to define part of how they expect to respond to. Leaders are expected to provide authentic hope and confidence. And so what I mean by that is, if you've ever been in a situation where leaders are constantly, all hands in, team break, that only goes so far. Some of the ways that you can express authentic hope and confidence is to be vulnerable, be transparent, and be frequent in your communications with your staff. During a crisis event, you want to understand the frequency of communications that your staff wants to hear from, the different modes of communication that would be helpful for them. During crisis, there was so much information passing through our email inboxes and everywhere else. So it's not a bad idea to poll your staff and really understand what's the best way to be communicating with them and how frequently are those communications needed. On the flip side, after an event, or as the event starts to wind down, you want to have a plan for winding down your communications, and really express clearly why communications are changing, or the frequency of communications are changing, because perhaps the risks or the nature of an event is evolving and those communications are not as needed anymore. Lastly, for today, building collaborations. So recognizing that in a crisis, patients and staff experience increased need in a lot of different areas that may include mental health and social support needs. And so one of the things to be thinking about during an event, prior to an event, after an event, are what are the supports that my team needs, my organization needs, in order to restore themselves and recover. Think about how, as you think about different strategies to support your team or your community, think about how they experienced an event differently, or the nature of the vulnerabilities that still exist that may need to be addressed or alleviated to promote them to restore and recover. I know Dr. Angie Im will be going through a number of different strategies for addressing several of these things. So also, I'll just touch on different partnerships for addressing social needs during a crisis. We know that often times our staff and our community are affected by childcare needs, by transportation needs. All of these things can be affected through any kind of disaster event. So if, as a leader, you have a list of resources readily available prior to an event so that you can just share it when something happens, if someone needs it, that would be most helpful. Oftentimes you'll want to work with your HR teams to build this out, if you have an HR team that's available to help you. I know for our organization too, we have an employee resource support program. They go to a website or they call a number, and it gives them access to a number of different benefits and support needs. If you have a colleague in administration or HR that can help you build out those resources, move forward with that. Last few Slido questions to go over. Reflecting on COVID-19 and your experiences there, but also maybe other events that have happened to affect your organization or your facility. What kind of partnerships did your organization have in place to support patients and community members during COVID-19? In some cases, this might be translators that help patients get access to services. In some cases, this might be building better connections with other community-based organizations within your community. While folks are writing out their response, one more question. What kind of partnerships did your organization have in place to support staff during COVID-19? Would love to hear about any and all experiences, kind of what worked, what great examples that you saw, or maybe if there wasn't enough investment in that during an event and you would like to see more. So in thinking about partnerships that organizations have had in place to support your organization during COVID-19, responder says, city and state health department, we were stronger when our work dovetailed and linked back to each other. Absolutely. Who are your points of contacts within city and state health departments or your local emergency management that can provide those resources? I think that's it. Okay. Last question. What partnerships did your organization have in place to support staff during COVID-19? Again, sometimes that's us as leaders supporting our staff. It's great if you can have existing coalitions or working groups within your organization so that people can lean on each other and learn from each other, like in this training. All right. Thanks so much, everyone, for all that you do every day. I'm happy to pass it back to Sabrina now for the rest of the presentations.
Thank you, Angie. And we have one more person typing in a response. Nope, they're not typing in the response. So I'm going to go ahead and move forward. Really appreciate your presentation, Angie, and really giving us a lot of insight on what is it that we really need to focus in on when we're leading during a public health crisis, and the extent to which that is important to preparing our team and making sure that they're doing well as they continue to move forward through a crisis. We're going to skip through the questions and comments and then come back to this after Dr. Wachuku's presentation. And so at this point, I'm going to ask that we advance to the next slide. And I'd like to invite Dr. Wachuku to talk about strategies to support the workforce. Thank you, Dr. Wachuku.
Thank you, Sabrina. My name is Ijama Wachuku. I am thrilled to be here with you. And I'm thrilled to be going after Angie, who, again, just delivered a lot of necessities we must think about, we must prepare, plan ahead for within our organization so that structure is in place when these crises occur. Not if these crises occur, when they occur. So if you look at the next slide, I'm just going to give you a quick overview about some of the stressors that we see among clinicians. And I'm going to tell you right now, I'm not going to read to you. I want to dialogue with you because this portion of the presentation is going to pull on your experiences, what you experienced, the strategies you use to get through, what you wish was in place. So I'm not going to read to you at all, but you can see some of the typical stressors there between workload, stresses that are associated with physical fatigue, emotional fatigue, social fatigue. These things aren't on there, but for those of us who were in healthcare, and I think most of us were, during the COVID-19 crisis, or any other crisis, as Angie mentioned previously, it could be any natural disaster. We know that these are real things. So even though we're using COVID-19 as this point in time, a more readily available reference that everyone can share and understand, I suspect many of you already have other examples that are right at the tip of your tongue, right at the tip of your brain, that you experienced prior and maybe afterwards. So again, I'm going to be speaking in terms of when this occurs, talking about prepping, getting ready for when it occurs. And I'm also going to be emphasizing that I need this information to be taken back and cascaded. Share it with your colleagues, share it with your supervisors, share it with those who report to you. Share this information. Don't let this information stop here. If you look at the next slide, you'll see that there are 3 dimensions of burnout. We all know what the term burnout is, and we know that healthcare providers have really high levels of burnout. That has been just a staple. That's nothing new. COVID-19 didn't bring that about. That has just always been our staple. It's because the type of people we are. We're the type of people who are the first to race in, put our well-being at risk because we love caring. It's just who we are. It's ingrained in us. So there's a certain type of person who goes into healthcare, and that's us. So you'll see Maslow's dimensions of burnout, where you see that feeling of energy depletion, exhaustion, that increased mental distance from your work, and just reduced efficacy. So we see that we just can't function to the degree, to the level that we need to. But we can't be there for our clients. We can't be there for organizations if we're not there for ourselves. First and foremost, we have to be there for ourselves. So burnout is defined as this, it's occupational, right? Is a syndrome that results from this chronic workplace stress that's not been successfully managed. So we can avoid burnout. in the workplace by putting a lot of the things that Angie discussed in place ahead of time, because it's not if it'll occur, it's when it'll occur. Okay. So there's those three levels: that depletion, the mental distance, and then the reduced efficacy. If you look at the next slide, you'll see that, can somebody help me out with that term? It's newer, moral distress, moral injury. It's a newer term. I don't know how many of you are familiar with it, but it's something that we started talking about a lot more in the field. Somebody help me out. What is your understanding? What have you heard about moral injury, moral distress?
Hi, Dr. Wachuku. I can talk a little bit about this because it's something that ACU's been working a lot on. And that is when we're unable to do what is needed because of some of those structural factors that Angie talked about earlier. So for example, we know that a lot of our patients might need vaccinations or testing, but there's just not enough tests or vaccines that are available to our patients. We know that we don't have enough hospital beds, and during the early part of the pandemic, we saw that there were patients who had passed who were being loaded up into trucks, and that created a lot of moral distress because of the environmental factors that we had no control over, and that in itself can result in moral injury, which has some physical impact in how we are able to engage and perform. And so it's a little bit different than burnout, but something that was very real that happened during the pandemic.
Absolutely. Thank you. That was perfect, Sabrina. And the thing that we have to be aware of is that we are very susceptible to it because of the type of work we are and because of the type of people we are. So we're in the business of caring. And when we feel that our hands are tied, when we feel like we know what to do, we know how to help the person, but we cannot because these organizational setups, the way that we need to ration care, the way that we need to prioritize and triage, all of this really goes against the core of why we're here and what we believe in. And we might be able to do it for a little while, but eventually it adds up. So that moral distress adds up. And as Sabrina said, there's not just a physical, but emotional outcome to this moral distress, making these decisions that are just against our ability to provide the level of service, level of care where you just can't. And you can only do that for so long. I see a comment in the chat box. Can somebody help me read that, please? One of my colleagues help me read that.
Absolutely, I can do that. So the comment says, as a homeless outreach worker, for example, I experience moral distress trying to house my clients when there's very little affordable or safe housing in my city.
Absolutely, right on. Absolutely. So my hands are just tied. Your hands are just tied, right? I have clients, I can care for them, but either just the limited housing, safe, affordable housing, just that barrier right there ties your hands. Or perhaps it's a new ordinance, a new policy that's been put into place. Whatever it is, it stops us from doing what we can do so well and what we love to do. It just stops us. And to piggyback off of that, I have a passion for homeless outreach, feeding people, food insecurity, and helping people get to a place where they can stand on their feet. So when the pandemic hit, I was working at a food bank. I was volunteering actually at a food bank. And all of a sudden we went to tons of volunteers to two of us. We're down to two of us. And we don't know what this is. This is March of 2020. And so take yourself back to March of 2020. Take yourself back to the lack of information, lack of knowledge, lack of protective supplies, equipment, Take yourself back to that space. Lack of understanding of disease transmission. We didn't know what it was. Is this a virus? Is it a bacteria? Is it a fungus? We didn't know anything, right? So now we do. So I'm asking you to stretch your mind and take yourself back to March of 2020. I get why we didn't have any more volunteers. Yours truly, I don't know if that was a great thing or a bad thing, but yours truly said, I can't leave. I can't leave this population. So I continued going. I don't know what masks I was wearing or how many gloves I was wearing. Right? Again, it's March 2020. And all of a sudden, these individuals who are not just coming to us for food, but they're coming to us for interaction, connection, that soul connection, that spirit. We're not just feeding their bodies, we're also feeding their spirit, their soul, their emotion. And all of a sudden, there's distancing, right? Now we have our clients lining up in a parking lot. We're terrified, not just for ourselves, but for our families, and also terrified that, okay, we're down to 2 of us. If one of us gets sick, which one of us did, fortunately, all went well. If one of us gets sick, it's a big problem. So again, lots of moral stress with not being able to connect with my community, the people I serve in the way that I become accustomed to, and that took its toll on me emotionally. The anxiety, the frustration, the upset, the anger. Can anyone add to any of those descriptors? When your hands are tied, can someone help me with some of those descriptors? Some of those feelings. Short, right? And that's what I say a lot of times when I talk about this topic is when your colleague, I'm picking on you, Angie, when your colleague Angie is not quite who she usually is, instead of stopping and saying, what did I do to Angie? I always, offer her a muffin in the morning and she just snaps at me. Stop and take a second and try and figure out, be there for your colleague, figure out where Angie is, approach her. But and I'm going to go back to Angie's presentation. We have to set that culture. And I'm going to be talking throughout about setting that culture, normalizing it, normalizing the communication where it is accepted. And I say, hey, Angie, is everything okay? You seem, whatever the descriptors, you seem stretched, you seem short, you seem tired, whatever it is. My words don't have to be perfect because we've created that culture within our organization where I can approach Angie and Angie can approach me and Sabrina can approach me and we can do this. So if you look at the next slide, it talks about phases of a public health crisis. And a muffin or a snack would definitely get me talking. Me too. That's why I gave the example. Thank you, Angie. So the British Psychological Society has a guide for healthcare leaders. And it talks about 4 phases of a public health crisis. And again, I'm not going to read to you. So go ahead, let's look at the next slide and let's talk about those phases in detail. So the preparation stage, the active part 1 phase, part 2 phase, and recovery. Let's delve into those. So when we talk about preparation in the next slide, when we talk about the preparation phase, some of the key features include preemptive anxiety, right? We're kind of revving up, right? We're going to fight or flight mode, right? We're kind of almost excited, anxious. And I talk about eustress and distress a lot. I'm also a professor. So when I'm talking to my students or talking to a group of individuals on anxiety, stress, healthy stress, unhealthy stress, we need a certain amount of get up and go, stress, anxiety, motivation. We need a degree of it, right? But when it gets, and that's where you have this U-shaped curve, right? This opposite, this bell-shaped curve, right? So as the stress is mounting, it gets us out of bed. Okay, today I have to meet with the homeless commission in my city and super excited, have everything in place. So as the stress goes up, our performance goes up. Our performance goes up naturally, as you anticipate, up until a certain point. As the stress continues rising, our performance goes down, right? And that's where we start seeing marked problems with anxiety. But this preparation stage, this early, get your behind moving. Yeah, we need this. This is good, right? However, some of the characteristics when it's a crisis, you might not feel completely prepared. There's uncertainty. You might feel overwhelmed. You might be worried, and then that stress gets a little higher than we want it to. So we need the stress. We need the, okay, let's do this. Go team, fist bump, right? Next slide. You'll see that in the preparation phase, some of the tactics to support yourself, right? We're checking with our teams. We're implementing a lot of the stuff that Angie talked about in the first place. We already have our organization set up in the first place to allow us to experience this and go through this well, right? So these are some tips. These are some tactics for yourself and your team. Next slide, please. We get to the active phase. Some of the key features, the heroics, the search to solution, some of the identifying characteristics you can see there, right? The camaraderie, increased morale, the let's do this, the fist bumping, we got this, the you okay, let's do this. Some of the hazards, we start kind of going off of the instinct because we're in a crisis mode, right? So we start going off of instincts. So we kind of throw traditional things out the window, right? Some of the things, the protections, the setups we have in place to ensure things go well. Did we double check the medication vial? Did we scan it? Are the codes? Some of those things might start slipping, right? Are the codes correct and appropriate for this particular patient, right? We know this, we're in a crisis. It's not going to be as clean as when we're not in the crisis. So those are some of the hazards, the frustration, the confusion. How about when you're asked to step in a role that's not usually yours? Sure, you're a nurse, a seasoned nurse. You've been doing this for forever, and you've worked in all areas of the hospital. Recently, though, however, you've been in ICU, or you've been in med surg, or you've been in maternity ward, whatever it might be. So, hey, we've got nurses. Let's get those nurses in, right? They're nurses. It represents a change and role confusion and the degree to which you might want to or need to check with somebody who's more traditionally in that role. Do you have that access? Do you have that ability? Again, we're in a crisis. So you need to be really cognizant of making sure people are clear on their role, the boundaries, what's the correct step versus an overstep, right? Okay, but this is still exciting. Our healthcare heroes, we all remember that. That's not a new phrase. Healthcare heroes. There's this outpouring of love and support. And oh my goodness, you guys are wonderful, more wonderful than we even knew. Oh my goodness. Next slide, we're going to talk about the active phase, where you have tactics to support yourself and the team. So we talked about modeling healthy work-life balance. We talked about modeling. We talked about all of these are things that we need to be seeing from the leader, but also need to be seeing from our colleagues, from ourselves. We're kind of all responsible for this, right? So these are tactics to support yourself and your team, okay? That work-life balance. Normalizing asking for time off, taking time off, saying, you know what, when I ask Angie about that muffin, this muffin is going to carry through the entire presentation, I suspect. When I ask her about the muffin, and she's not her usual, Angie self, when I offer the muffin, has it been normalized in our organization for her to say, you know what, thanks for asking, Jama. I'll be honest, I'm really exhausted. And I'm feeling a little scared today. I feel like my head's in a lot of different places. Has that language been normalized in your organization? If it hasn't, it really, really needs to be. And I'm imploring you to normalize that in your organization, normalize that degree of honesty, vulnerability, but you have to set that safe space environment in order to do so. Please continue to the next slide. So part 2, we were healthcare heroes. I don't know if any of you experienced this, but there was also some kind of stigma to us, right? She's working with those homeless people where we've already had a stigma for decades and generations, right? And now she's volunteering with those homeless people. We don't know what this COVID is. Is she safe? Can we be around her? She's kind of ew. You know, people who wear scrubs were a little bit ew, right? We were heroes, but at the same time, there was some kind of stigma associated with us, associated with our scrubs, associated with the population in which we're working with, more so than usual. Can I get a show of hands? Can I get someone in the chat box, jump on your mic? Is it just me? Was it just a Southern California thing? Or was there any kind of degree of stigma of you wearing those scrubs or wearing the badge of this is what she does for a living, this is what he does for a living, this is what they do for a living, and then walking in and people are kind of looking at you with the side eye, you're a hero, but don't come too close. Anyone? Maybe just me?
Hi, Dr. Wachuku. Yeah, in Nashville, when we were serving meals, we didn't want to get too close to folks because of the 6-foot rule, and people were upset by that. People who didn't know about that concern, and so we had to, have conversations with folks about why we were doing that. But it definitely created some tension.
Absolutely, absolutely. Thank you, thank you.
You know,
Next slide, please. Oh yes, please, Sabrina, jump in.
I was just going to add, just recalling back to the early stages of the pandemic where we and a lot of our health center partners were ready to step up, and we did, but we worked ourselves into exhaustion. And so kind of heroic face moving into I am now burned out and I'm tired and I need a little bit of support and help here, not only with the actual work we're doing, but to take care of myself.
Yes, ma'am. Yes, ma'am. Absolutely. Thank you. And the help with the work you're doing and taking care of yourself, I don't know about you, but it wasn't coming. It wasn't anywhere to be found at the time. So you just kept pushing yourself. Absolutely. So tactics to support yourself and the team. Here's some tactics. Here's some tactics. But again, I'm going to go back to we have to normalize this stuff now. We're not waiting till we're in the public health crisis, because I'm sorry, by the time we're in the public health crisis, we're in the middle of it. And I don't know, Sabrina might not be terribly comfortable asking for help, or she might ask for help. And because I or her organization hasn't gotten to the place where we've normalized this, we see this, it's our culture. We've created that culture. It's like, Sabrina, we're all tired. Even if I don't say it, I'm thinking it and I'm treating her accordingly. Might not be directly, but we need to change the conversations, the language surrounding this, right? Okay. So this has to be all of these tactics. Again, I'm not going to read it to you, but all of these tactics, and you'll get a copy of this after the session. All of these have to be in place ahead of time. Next slide, please. Recovery phase. Some of the key features. The psychological impact. We're just seeing that psychological impact now. We're seeing the rates of people leaving the field. We're seeing the distress, the emotional distress. We're like, oh, things are back to normal. No, when such a huge impact has been made on people emotionally, because physical injury, and not to downplay it, but bones heal a lot more directly than psychological, emotional wounds, right? They really do. So we are still in that recovery phase, and we're still seeing the impact. And that's another challenge, is people who didn't experience that crisis, again, whether it's COVID or whether it's some other natural disaster or something else. Maybe it was something specific to your organization. People who didn't experience it might have that, you're still there? Because we do live in a more individualistic society in the US. We're bootstrap people. We pull ourselves up by our bootstrap. So things like prevention, what we're doing right here, things like prevention has not been normalized. Those of us in the field and in public health and in prevention, we're all about it. We're all about it. We know that it's better, easier, more effective, just all of these words I'm not going to take the time to articulate right now. Prevention is where it's at. However, look at the amount of effort in our society that is put towards care after the fact, trying to recover, versus prevention. The amount of prevention dollars we spend, that our government spends compared to care dollars, it's just off. It's just off, and we're slowly getting better, and that's awesome. We have a lot of excellent organizations, excellent grants, excellent efforts such as this. That is made possible because we are recognizing on all levels, individual, societal, neighborhood, community, governmental levels, that we do need to invest in prevention. That's the best way. But prevention is still far behind, and we need to get better at it. Next slide, please. So the recovery phase, some of the tactics to support yourself and the team. We got to talk, people. We got to talk. We need to listen. We need to connect. We need to give the kudos, the good job, well done. We need to acknowledge, we need to see each other. And we need to involve. We need to involve everyone. And when I talk about involving people, even with sharing what you take back from today, as Angie said, we know your time is so valuable, and coming here to invest in this, that's a big deal. So applaud to you. But when we involve staff, think of all levels of your organization, because all levels get impacted. The degree that HR got impacted, that IT got impacted, and I'm going to go ahead and stick with COVID-19. That's the example we're using. IT, they were heroes. They are heroes. They're still adapting to all the changes we had to make. Heroes. I didn't see banners for IT. And again, I am not, and by any means, trying to downplay frontline staff at all. But I am just asking you to be cognizant of all levels of your organization. Your office coordinator, hero, HR, oh my goodness, the policies, the changes, heroes, IT, I'm not even going to go into it. It's why we're here. It's why we're emphasizing disseminating information in this manner. Our IT people, they made that happen. So we need to change the culture. I'm going to keep saying that. That's going to be my theme. As you're reading these slides, this is going to be my theme, is we have to change the culture. We have to talk. We have to listen. We have to loop back. So Angie, case of the muffin, so Angie shared this with me. She shared that she's not, that she's just not in a good space because we've created that culture ahead of time. So it's a safer place for Angie. It's a safer place for me. It's safer for all of us. So when we have the conversation, I have options. Hey, during lunch, you want to meet up and take a walk? If we're virtual, hey, can I call you during lunch and maybe we stretch together? Whatever it is, I don't know. You throw some things in the chat box. You have ideas, throw some things in the chat box, whether it's in person or virtual. I need to loop back with Angie. She shared, she made herself vulnerable because that's our culture, but I need to follow through, check back in. Next slide, please. So interventions for clinical well-being, right? So I talked about the various levels. There's an individual level, organizational level, and societal level. And not just this pandemic, but pandemics in general always see this casualty, this great morbidity, this great injury, damage to mental health of clinicians. Anytime we're deploying people in any type of high stress situation, we're going to see it. So some of the research that we've seen, when clinicians circle back and say what we need, some of the emerging themes of what we need is the need for resilience and stress reduction training, giving clinicians basic stuff, food, drink, childcare, specialized training. You put me in a new role. I need training. I need to understand my role. I'm a nurse. I jumped in. Help. Talking about moral injury, because that's one of the things that we don't talk about is moral injury, is because we're ashamed of it. We're frustrated. We're angry. We feel shame. I'm not used to having to pick between a pregnant mom and another pregnant mom or an elderly person. I usually don't have to make these decisions, and all of a sudden I'm making them multiple times a day. It's a lot, and I don't want to talk about it. Create that culture now. Normalize seeking healthcare. Normalize talking about mental health. Next slide, please. So interventions on the individual level, these are some of them. Again, I'm not going to read it to you because we will have these available to you. But planning ahead, communicating well, communicating 360. A lot of us are familiar with 360 evaluations, where we get communication from those who work lateral to us, report to us, and those we report to. We get that 360 communication. That's so important, is to have that information, have resources available. Your HR, whoever serves as your HR, has that available. Things that are actionable, things like I've gotten suggestions such as staring at a candle, smelling scented oils, whatever it may be. These are individual things that we can do to reduce stress. Next slide, please. Monitoring and supporting clinician experience and the psychological impact. Rotating workers, so it's not just one set of workers, especially, wow, she's really good at this. She manages that so well, and then that person ends up more likely to burn out because she does it so well, and now she's the one who's always in the ER, right? Trainings, trauma, coping, mental health, resilience, trainings, feedback, checking in on people that you know have vulnerabilities, and that's support. Next slide, please. So this is just an example from the field. I'm going to give you a second to read it. And again, if you don't finish reading it, you will have access to it. Grant opportunities are such an important way to give people access to more support, information, tools, etc. Partnering with your schools, partnering with public health. Next slide, please. And I already said, we're not very good at talking about moral distress, moral injury. We're not good at talking about it because we don't want to be there. And we feel some degree of sadness, shame, distress. We're superheroes. We go from one patient to the next, and supposedly the slate is wiped clean, right? I just had to make a decision between that pregnant mom and that 10-year-old kid, but my next patient expects me to show up 100%, or at least 95, and I'm just not. I'm at 60% right now. but I'm still trying to show up as well as I can for that patient because they deserve it. We got to take care of ourselves though. I have a Slido coming up. I want to hear what you guys have to say. So the next slide, how does your organization approach the topic of moral distress and injury? How are staff supported? Take this back, my friends. Take this back to your organization. It's through us that the culture is going to change, and we need it. We are at such risk. We're at such risk in our professions. Weekly team check-ins. Excellent. Normalizing the talking, the checking in. An on-site psych team, we can make 30-minute appointments if needed. That's awesome. We also have HR in-house for weekly visits to discuss those types of issues. That's awesome. Clinical staff feedback tends to be more valued than support staff in terms of moral injury. So partnerships between clinicians and support staff have been the best way to achieve system change. I love it. I love it. That's that remembering everybody in your organization, from environmental services to the people, depending on the size of your organization. I was in a hospital at one point, to the people who are cooking in the kitchen, in the cafeteria. Absolutely. You need to partner up. Acknowledging realities that impact our work, having leadership to advocate to improve those realities. Absolutely. This reminds me, all of your answers just in combination, reminds me of a wellness program I put together when I was directing community outreach at a large hospital. And one of the things I made sure that I did was we decided to do a race around the world. So I started this initiative, and one of the things that my team decided, hey, let's do a race around the world. So I grouped people based on making sure I intermixed departments, leadership, where people were in the org chart, whether it was the CEO, make sure the CEO was grouped with some people from environmental services, grouped with people from nursing, etc. It really enhanced the communication, the camaraderie, the advocacy that one of our colleagues right here just said. Clinical staff feedback tends to be more valued. So partnering between clinical and support staff, all of those things, having leadership to advocate for stuff. Everyone had somebody from a vice president on their team. So it was just a different way of putting wellness out there in a way that functioned. Access to therapists through EAP. I love it. And a lot of us don't know what access we have. So that I like that one of our colleagues put that in the Slido. Make sure you know what access you have. And if you're in a position, communicate it repeatedly, redundantly, frequently. Hey, remember that you have access to blah, 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 whatever it is. Repeat it, repeat it, repeat it, please. Thank you. Next slide, please. It's another Slido. We'll move through that one a little more quickly. Now we've got you geared up. Peer support interventions, circling up. So one of the things that somebody already said, the check-ins, circling up. Don't wait till a crisis has occurred. Rather, just normalize it. We're going to have a check-in, as one of our colleagues said. We're going to have a huddle at the start of the day or the shift. We're going to do check-ins throughout the day. We're going to debrief at the end of the shift. It's not because something happened. It's not because something's wrong. It's not because somebody's not doing our job. This is just how we do, right? We normalize it. It's our culture. Next slide, please. So on the individual level, and Angie started talking about this, model self-care, model help-seeking behaviors. I've already mentioned this. I just mentioned this, publicize the resources, develop the culture of caring. I think I'm just going too fast for my slides. And that anonymity, because not everyone's going to be as comfortable. And also remember the types of personality in your organization. We have some more extroverted people. We have more introverted people. We have people who are introverted versus extroverted, depending on the situation, depending on so many things, right? So keep all of the types of personalities, people, positions, keep all of that in mind when you're talking about wellness and ensuring well-being and the basic needs. Obviously, the basic needs, people can't perform well if they're stressed out about basic things that might already be available through EAP or human resources, or I don't know. But make sure you know what's available. Make sure you publicize what's available. Make sure you take advantage of it, and make sure you model taking advantage of that. You know what? I'm going to take some PTO. Not, oh my goodness, why would you do that? No, good for you for taking care of yourself. Next slide. Go ahead and jump in there. What trainings or resources did your organization offer to support staff well-being during COVID-19 pandemic? And if you can't think of any for COVID-19, think of any crisis in your organization. Think of any big events in your organization. While you're doing that, I'm going to model self-care. During one of my presentations a couple of months ago, somebody said, I like seeing you drink your water. So I didn't forget. I just wanted my big, loud pink and blue bottle to model self-care. Sometimes we don't even do that. The basics, stop for water. We're not stopping to use the restroom. We're not stopping to stretch our legs. We're saying, I can wait. Just one more second, just one more patient, right? Let me just help out this colleague. No, stop and drink your water. ProQOL, very helpful to complete annually, biannually. Do you want to jump in and share what that is? Or type more in the chat box or in Slido? I'd love if you came off your mic if you could, if you want to. You don't have to. Just because I get tired of hearing my voice.
Hey, this is Foster. The ProQL is a burnout assessment tool. So that was very helpful for our staff to do like once a year as part of seeing where we were in relationship to our work, and charting that change over time was very helpful.
Thank you, Foster. And this is one of the tools that we do list in a later slide as tools that you might want to take back to your organization. Next slide, please. How do you model self-care and help-seeking behaviors for clinicians in your organization? I'm drinking my water. Time off. It's really a thing. It's really a big deal. It really is. It speaks volumes, especially as a leader. To have times where you're not available. You have that work-life balance. Model that. Don't model being available 24/7. That is not healthy and it'll lead us to burnout. We have admin time weekly that we usually hold 30 minutes, massaging sessions and yoga, etc. Love it. Schedule emails to be sent in the morning if working at night. Yes, so people don't feel the need to check emails when not at work. Love, love, love. I will absolutely steal these ideas and share them in a future session. I always like to share what previous session participants came up with. Staycations, Sometimes just mentally, even if you can't take a long vacation, that's from one of my previous participants, just physically being out of the house at a hotel nearby or in the next city so that you feel like you're away. Yeah. Next slide, please. So so at the organizational level, so this is the Pro QOL that Foster that shared with us. There's the Maslow burnout inventory. That one's pretty well established. That's one of the oldest ones. Pretty well established. Other inventories have piggybacked off of that. There's the mini Z survey, but look and see exactly what they're measuring and which one's best for your organization, and use one of them, use some of them, use several of them, but also make sure you talk about the findings. Always bring data back. That's one of my other hats. I'm a researcher. Bring data back to the people you got the data from. It's respectful. It shows that you care, and it shows that it's meaningful. So when you collect data, analyze it, present it back to the people, and then discuss next steps so people have a say, so people know that you are invested, that you are serious, and that their voice matters. Next slide, please. Gross stuff. Has anyone heard of this? Hands, thumbs up, heart, whatever you want to do. Anyone heard of gross stuff? There's a lot of it. I mean, I think you've seen a lot of documentation just everywhere. I see thumbs up going up. So there's a lot of things that we do that we could save tons of time and information, energy, if we got rid of, right? Are there just too many clicks that are going on? Is our electronic health record system efficient? Are people just doing things so mindlessly now because they know that there's information you don't really need, so they just stop paying attention, right? Click, 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 click. And we're making mistakes because not you personally, but the organization or whoever it might be has set the standard that not all of this is relevant, and we have to get through the information. So let's move through it quickly. By doing that, we lose important information. So pare it down, narrow it down, reassess that form. Is it really important to have to ask for the patient's, whatever it might be, for the 100th time? Or is it already in electronic health records? We all know where to find it. We're getting consistent training instead of making the nurse collect the same information that the physical therapist did, that the occupational therapist did, that the respiratory therapist did. Gross stuff. Let's get rid of them. Let's review, not be attached to the stuff that we've done forever, and move forward in a streamlined manner. Next, please. So again, at the organizational level, training for new job roles that cause so much stress in crisis is you're being thrown into a new job role. You're in administration, now you're helping out, I don't know what, you might be working directly with patients now. You were at the front desk and now you are, supporting a different department. Help us understand our new job roles. Make sure you understand your new job role and know exactly what it entails and how to do it. That caused so much distress, added to so much burnout during COVID-19, right? Having enough training, again, I'm talking about changing the culture to organizations, right? Have enough training to be able to provide some basic psychological understanding support, first aid, if you would have it. Most of us know that if you get a cut, right, we wash our hands, we clean the area, we might use an alcohol prep pad, we might put a little antibiotic gel on it, and put a Band-Aid on it. We need that some degree of training in order to provide some basic support. Language, we need the language. We need referral. We need resources. We need to know what our organization has, what it needs. Is there a committee needed to talk about, where the gaps, the holes are, so that we can do better? Or maybe we have all the stuff and the information is just not being shared. But again, I'm going to make that link with physical and psychological, just like we look after basic physical stuff, and everybody has basic training on what to do if somebody breaks an arm. Maybe, I might not be able to set an arm, a broken bone, but I know that you need to immobilize it, right? We need that level of at least basic conversation around psychological distress. Next slide, please. How did clinician job roles change during the pandemic? I see someone typing. I see someone else typing. If you want to jump off your mic as well, anything you want to do. Tech support for telehealth. Yeah, absolutely. That was big. That was really, really big. It's like, I'm a clinician. I don't know how to, I don't know why your computer's doing that. And I never used to have to know. Increased use of PPE. Absolutely. Absolutely. Yeah, clinicians always use PPE, but definitely not to the degree as was needed during the pandemic. Yeah, somebody else agreed with telehealth. I'm a clinician. I didn't know that I needed to have a minor in IT. When dentists weren't able to see patients, yes, they helped with testing. So many changes and so many people weren't prepared for new concerns, HIPAA compliance, working from home. Oh my goodness. You guys are nailing it. Spot on, spot on. Yeah, now I'm working from home. Is my computer compliant? There's not enough devices from the organization, so I have to use my computer, but I have to make sure it's compliant and I'm storing information correctly. Absolutely. All important, of course. Had to provide more emotional support as patient family members died from COVID. Right, right, right. The emotional support. Absolutely. Next slide, please. How did you set clinicians up for success in these new roles? Or how were clinicians set up if you're not in a managerial role? Or were clinicians set up for success in these new roles? I don't know. Jump in, let me know. I don't know. That's the conversation we're having right now. Open-mindedness and ability to adapt. Yeah. Yeah, that was absolutely required. If you didn't have that adaptability, that ability to, you wouldn't make it. That flexibility. And that's what we're working on right now. That's why you're here. That's why I'm here. Next slide, please. Oh, somebody's typing. I'm going to start talking a little clear written procedures for new things. The communication just made a difference, made a huge difference. That consistently we got that. Where there was clear communication, people just felt better. Absolutely. Next slide, please. So at the organizational level, and we talked about this, I talked about transparent, talked about bidirectional, I talked about 360 to make it directional in all different areas. And I just said it, communication empowers teams and improves morale. People felt so much better when they knew what to expect, when things were clear, when things were transparent. A lot of times was the difference between success and struggle. Next slide, please. At the societal level, advocate for and engage in federal programs to care for clinicians. We talked about seeking grants. We talked about working with your public health department, your local university. learning communities, sharing interventions that have been effective at your site. Collaborate. That's imperative. Next slide, please. So this is a practice highlight. I'm going to give you a second to read it, but again, you'll get these slides, so you'll be able to see these. I keep going back to basic needs because I think, especially as superheroes, it's assumed that we have everything together. We just don't. I'm struggling, you know. Maybe I have transportation challenges, I have childcare challenges, I know all the myriad of challenges. But I show up, I do my job, I do it well, and sometimes our basic needs don't get met. Talk about that, bring that up. Next slide, please. These are some of the ways that basic needs can be met. University of Utah had a COVID work group. These are some of the things they came up with. These are some of the people who are at the table, the frontline teams, HR, operations, nursing leadership. Again, make sure you look at your organization, involve the people who need to be in that conversation. Next slide, please. So when support services are needed, when it's a low-risk situation, when the person is just, they're starting to not feel ideal, it could be classes, it could be support groups, it could be hotlines, it could be Facebook groups, ways of connecting with others. It could be articles, ways of connecting with others when it's low risk. When the risk is getting higher, we need to be a little more proactive. We need to be proactive. And when it is high, that's when we need to be getting referrals, getting professional help, getting EAP, crisis lines. Absolutely. Next slide, please. Recognize people, see people. We want to be seen. Others want to be seen. See people. And working in health outreach for so long, there's so many organizations, businesses in the community that will support you, that will donate stuff. Oh my goodness, it just wasn't hard when it's for something that is for outreach, for support. It's really just about communication. I honestly never had trouble saying, hey, we have this community event where we're trying to fill in the blank, help individuals get screenings, whatever it was. I was always able to get raffle prizes, tickets, restaurant vouchers, whatever it is. Recognize people. Work with who you need to recognize people. Next slide, please. And this that we're sitting in right now is part of that communication effort, part of that resource effort. And again, I challenge you, don't let this information stop here. We ask you to take this back to your organization. Next slide, please. This is another example from the field. And I like this. It's just, again, what we talked about before, normalizing that at the beginning and at the end of the shift, in the middle of the shift, normalize behavior. What's been bad? What's been good? What's worked? What hasn't worked? Safe space, but we've created this culture. So this example from the field, you'll see that the culture has already been created, right? Culture's already been created. Next slide, please. This is another example from the field. I like this one because it brings that spirituality aspect. And again, it's not for everybody, but it is for a lot of people. So, right, holding devotionals every morning, people have an area that is safe. We see the impact, emotional, physical, spiritual, social, financial, all of these areas of our lives are impacted. And the more that you can address, the better for your colleagues, for yourself, for your organization. Partnerships, partner. Next slide, please. going to go ahead and pass that on to my colleague, Sabrina.
Thank you, Dr. Wachuku, for your presentation. Before we get into Q&A, I just do want to plug a couple of resources that we have available through the NHSC Empowerment Initiative. One is a quick reference guide, an infographic that you can use to remind yourself of 10 ways to support clinicians during a crisis. And then we also have a more robust guide that helps you understand the different burnout tools and how to measure burnout during a crisis. So I encourage you to look at those. Those are available on our publications page, and you should see a link to that in our chat. Next slide, please. And so at this point, I just want to see if there are any questions from the group. Unfortunately, Angie did have to step away, but we still have Dr. Wachuku, and then we also have our team from ACU and APT who can help respond to any questions that you might have. And you can either include them in the Q&A box, or you can raise your hand, and I'm happy to answer any of those questions. And while we're doing that, I know that we just have a few minutes left. I do want to remind you, if you're able to complete the evaluation at the end of the session, please do so. That's really important for us to be able to improve the quality and content of these sessions.
I have a question, Sabrina. And Dr. Wachuku, I'm curious, I've worked in environments where sometimes clinicians have gone through a traumatic experience, and it could be, working in a public health crisis and all of the emotional exhaustion that can come from that kind of situation. Have you ever run into a situation where clinicians maybe don't feel ready or open to getting support, receiving that like mental health support? And what would you do in that scenario?
That's an excellent question. Unfortunately, it's the norm. It's the norm. We're heroes. There's a degree of stigma and shame associated with healthcare providers needing help. You need support, Foster? You, Sabrina? You, Molly? Yeah, no, it's the norm. So unfortunately, that's actually more prevalent. What I would do in this situation is let the individual know what's available, that you are available, but I would start even further back. We have to back it up by changing the culture. And that's why I'm imploring everybody to please go and start using language. We're okay talking about physical health. It's okay for me to say, oh no, I can't eat that. I'm diabetic, right? A physical health challenge. I can't say, oh, you know what, that would be a little too much for me. I just struggle with anxiety. I do have phobias. We can't say that. So I have to back it up by imploring that we start changing the narrative, the language, the culture, and where that has yet to happen, I would model it myself. And you heard me use a lot of examples that were personal to make it clear that there is no shame in the fact that, I might have anxiety, I might have depression, I might have whatever. We need to start modeling it. We need to create that safe space. We need to say, hey, you know what? I just want you to know that I am here for you. So if you do have any challenges, this is something I've struggled with. I know other people struggle with. If you're open to doing that. But it backs up by changing the culture.
Thank you, Dr. Wachuku. So that is all the time that we have today. And I want to thank everyone for attending today's webinar. I want to thank our presenters and our tech support team who made today's webinar possible. Just a quick reminder that the PowerPoint slides and related documents are available to you on our webinar registration page linked in the chat. And then I do hope that you'll join us for our next session, and that will be coming to you in an email from the National Health Service Corps Empowerment Initiative. So be on the lookout for those emails for upcoming sessions and links to these resources. Thank you so much, and we hope to see you next time.